Super. Now it gives me great pleasure to introduce Professor Richard Keane. Richard's a colleague in the UK who's a consultant rheumatologist and developed the metabolic bone disease service at the Royal National Orthopaedic Hospital in London in the UK. He's a very active academic, a principal investigator for many clinical trials, and is also the chairperson of the Scientific Advisory Board for the Brittle Bone Society. Thank you, Richard.
Thank you very much indeed. And so I'd like to thank the organisers for inviting me to speak to you today. What I'm going to do is talk a little bit on my sort of the practical things of sort of assessing pain in adults with OI, but also we'll touch a little bit about some of the other conditions. And again, I think what's great about the meeting over the next 2 days is we realise that a lot of the themes that we see in osteogenesis imperfecta are also shared by a number of other rare bone conditions. And I think it's really important that we learn from each other. I think also what I'm going to try and sort of allude a little bit is to sort of the practicalities of perhaps what you see in research, but also what it's like on the sort of coalface of clinical practice. Because again, I think in our experience in the UK, what you'll often find is that a lot of the children's services are very well resourced. There's lots of input for that, but in the adult world, it's not quite as easy. And I'm sure a lot of people here will probably share those experiences. So I'm just going to try and sort of again try and highlight some of the good things, but equally some of the other things that where the challenges exist. So those are my disclosures. So again, what I hope at the end of my sort of 10 minutes or so is that, yes, we know about pain, we're going to skip through that, but it's going to be sort of how we're doing, how we assess, and basically understanding what tools we could be using. And again, we've already heard a little bit about some of the pitfalls of some of the tools that are there. So again, I think as a clinician, and again, I'm trying to put this from my side, we are very good at sort of, we can differentiate our pain into sort of, a sudden onset pain, and often that might be a fracture that a patient might have experienced. But equally, it could be a sudden onset of lower back pain. But just trying to understand, the acute pain, and we're going to hear tomorrow about sort of how you manage that, particularly in the surgical setting. Obviously, long-standing pain, and again, a lot of people here will be aware of that. And then again, you're going to get the pain that comes and goes. And of course, sometimes it's not knowing, is the intermittent pain going to last a long time? Is it just going to come and disappear? So just trying to be aware of that. I think also when we're talking to you as patients, as individuals, as people, it's trying to sort of understand, again, once we start going down these diagrams, it's sort of trying to understand, well, some of you will know, we always hear patients saying, I just know it's my bone pain, or is it general bone pain, or is it sort of more just generalized pain, or is it from a particular organ? And again, we need to sort of understand that, and not all the tools that we use to assess pain sort of give us that breakdown. So it's often just, have you got pain, yes or no, or yes, maybe it's in part of the body, and we'll talk about that. But essentially, how we capture the pain isn't always going to tell you what part of this pathway things are coming from, and we often will use key words, again, particularly to the right of that, to sort of look at this, the sort of neuropathic pains, the burning pains, and we'll talk a little bit more tomorrow about how we will manage those pains. This slide I think is quite interesting and quite sort of again thinking of the wider spectrum of people with other conditions. So this was sort of a review over I think it sort of went back over 60, 70 years, looking at various publications that have been looked at, looking at sort of pain and the various diseases. And you've got sort of OI, you've got Ehlers-Danlos, achondroplasia, FOP, fibrous dysplasia, and CRPS. And you can just see the sort of the spectrum of the sort of the pain sort of areas that individuals or the studies had reported. So again, sort of you can see sort of lots of different areas. But again, as was alluded, what might be the general population? Again, we all suffer a bit from back pain and things like that. But you can sort of see the sort of the spread of things. And again, if you sort of look at the sort of slightly browny colour, that gives the sort of the studies that have been reported in the OI population. So again, just gives you an idea of the type of areas that individuals would be experiencing pain. And again, I'm sure a lot of you can can relate to that. This is some data from the UK, from the Rudy study, looking again at sort of 2 or 3 different conditions: osteogenesis imperfecta, fibrous dysplasia, and XLH. And again, you can see sort of the idea with regards to the sort of whether things are impacting significantly, sort of no problems at all. And again, you can sort of see there's a fairly broad sort of similarity between these conditions with regards to how they were assessing the pain. We've heard the data from this study already, but again, I just thought it was quite interesting, just in a sort of very simplistic way, to highlight, that when you just asked people, how the impact of pain on their life in the adult population, again, you can see 83% experience some pain, and again, you've got sort of the distribution. Again, we've seen that slide earlier this morning. I think what's important for us in clinical practice when we're seeing individuals who have OI, and this again we're going to hear more in the next day or two about the impact sort of survey. But again, when you look at the adult population, these sorts of studies are really important because there's probably quite a dearth of sort of research being done in the adult population. But again, you can see pain is the highest scoring thing on the far left of that on that graph. You've basically got pain. And actually, again, how often do you get that time in the clinics to talk to people about the pain they're experiencing? Whereas, often people will be focusing more at other ends of that sort of graph, about maybe the fractures. But actually, that's not such a big thing for the individuals who have the condition in some situations. So again, I think we need to change our mindset in the clinical practice. But also, perhaps, again, as we alluded to in the clinical trials, maybe what's really important in bringing patients into the clinical trial development programs, you want things that probably are going to impact more on the left-hand part of that graph rather than on the far right. And again, I think that's really important for us in the clinical services. But again, as we alluded to, sometimes to assess pain, it takes time. And we don't have a lot of time in clinics sometimes to see individuals. And again, that's a challenge. And that's something, again, that we need to think in resourcing the clinical services for individuals with rare conditions. We've heard about these tools. Again, visual analog scores, very simple, but actually not that useful. Everyone's perception of what's a 7, what's an 8 is very different. We've heard about these other tools on the right as well. Again, do you have them as paper tools? Do you use them online? And also, sometimes you can collect them. And again, but in our situation, who's actually going to analyse them and score them? Because you can have all these questionnaires just sitting there and no one's going to use them. So again, it's actually, you've got to work out ways. And again, it's maybe ones that are electronic are better, because then it can all be happening in the background. But I know we've got questionnaires that are just sitting around and no one's actually analysed them. And what's the point of that? I think it's important that you can do them before you come to clinics, so then we can see them. It's no point you filling them afterwards. It's got to be done in real time. Otherwise, you're always playing catch up. We've heard about. In our practice, we use BPI. It's great in some ways. It gives you. But again, if someone's got generalised pain, that mannequin would just be completely shaded over. It doesn't actually help you in that respect. It's great if you're interested in someone with an osteoarthritic knee or a hip, but actually it's not so good if you're sort of dealing with generalised pain. But it's a tool that's been validated and it's used in quite a lot of the adult pain world. You can use these joint-specific. Again, I work in an orthopaedic hospital, so not surprisingly, I'm going to sort of say, but there's the Harris hip score. So these are scores that you can just, if you're interested in pain in a particular joint. And again, you might use these pre and post surgery. So you've got sort of joint-specific scores, and then on the far right, you've got the WOMAC, which again people can use for hip and knee problems. Now that might be quite useful for conditions, say, as XLH, where we know people can have more arthritic problems. But again, in something like OI, it may not be so relevant. But again, there are just other tools that have been used. Again, this was a study looking at the number of sort of the tools that had been used in various diseases from adults, and there were less of these tools had been used than in the paediatric world. But again, what you can see is in the sort of the second along is the number of tools that have been used in adults with OI, and you can see that there was a mixture of some had used SF36, EQ5D. Promise, and these other tools. So again, not a huge number of studies that have used that. And again, I think someone made the very important point. Some of these, you don't have open access to as easily to sort of to get hold of them. So again, in our practice, we do use SF36, we use EQ5D, and we use the BPI. But again, the number of tools against a lot less, and so the adult world is not as well researched as the pediatric. This was some studies, this was just some work that we did in our clinic, and Sophie Barlow, my colleague, has published it, and she's going to be talking tomorrow. But again, this was just sort of 50 consecutive adult OI patients that came through our clinic. And again, you can see sort of the distribution of the areas of pain they were reporting. And again, the lower back coming up as a sort of common site of areas that were affected. And again, you can see sort of the impact on the pain assessed with the EQ5D. And again, this is something that we're following on with, looking at sort of how that would actually translate into sort of ongoing, to sort of try and differentiate a bit more. Again, but Sophie can fill you in on that. But say essentially, you can see the distribution of where they're experiencing their pain. Not all of that is due to fractures. Most of these patients are not coming with fractures into the clinic. So I think, to me, from the clinical practice point of view, the first thing is taking a patient's history is really important. We see patients who, will be talking about their pain. Some of them will say, "This pain I know is my OI," and I know I think I want a particular treatment for it. Sometimes, we've also got to be aware that, not sometimes you'll see clinicians and they will perhaps think that all your pain is due to your OI, and actually you've got appendicitis. And actually, so sometimes actually you can't get to see people. Everyone puts you down as it's always your OI. So we want to make sure that we can do a history. History also, again, so you need the time. We can do that remotely. We can take a history from you. So again, one thing we had to do in COVID is to actually sort of engage with people more remotely. But again, that means you can talk to the specialists, and that's quite useful in the adult world. We can't examine you, though, physically over the internet very easily. So again, sometimes you do need to examine, and that's really important if you're looking for specific areas where the pain might be a particular problem. Have you had a fracture? Have you got sort of some sciatic symptoms or something? So we can't do that. And we've got to beware red flags. Again, you don't want to be in a situation, it's just your OI, it's just your OI. We don't want to miss something. So again, all these assessment tools might miss sort of, something that's actually quite serious. So it's actually being aware of that, or giving you, as the individuals with the condition, sort of things to say, I think we could give you some red flags. That if you're experiencing this in your pain, then you need to give us a call, because there's something going on, there's something different. So again, I think there's a lot more work that we need to do in sort of assessing the pain in the adult world, but we're getting there. But I think again, with meetings like this, bringing all the expertise together, things are going to improve a lot. So with that, I'm just going to acknowledge my clinical colleagues, Dr. Bubbier, Martin Dudley, our clinical nurse specialist, Sophie Barlow, and again, the Brittle Bone Society, who have funded a lot of our sort of ongoing work in sort of therapy needs in adults with OI. So thank you very much.
Thank you very much, Richard. We've got a couple of minutes for questions, if anyone has any from the floor. I'd like to stand up. Richard, can I ask, while people are thinking, there are an abundance of questionnaires.
Yes.
And to really join up our global research, which is essential for rare diseases, particularly like Osteogenesis imperfecta, do you think we're anywhere nearer, in adults and young people, having a few targeted questionnaires that we can all use, that are quick, not too burdensome? Do you think that's going to happen before I retire?
How long? When are you retiring? I mean,
5 years.
5 years. I think it's challenging. I think it's really challenging. I think, again, the question, again, I think it was alluded to from the previous speaker about transition. I think that's really important. So, again, and often, we probably need to take some of the questions that are being asked in the pediatric transition world and then move them into adulthood. But I think it is really challenging. I mean, I think we're trying to choose what are your top 2 or 3. And again, I think you're right. The burdensome of, I think sometimes we, as a clinician, sometimes I think, oh, I can give you all these different questionnaires to complete as the individuals. It could be death by questionnaire to some poor patients. You can spend hours ticking through things, and a lot of the questions are quite repetitive in the various questionnaires. So again, I think it would be great if we could identify a core data set almost of questions that we'd like. But fingers crossed, we might be able to do it.
Hi, my name is Rebecca. I'm from Oslo, and I was just wondering, the patients that you see them on a routinely follow-up basis, or do they ask for a consultant? Do they ask to come to see you? Because do you think that would affect your numbers and your data that you're getting? Because that's the difference, I think, between pediatric follow-up and adult follow-up. A lot of people follow children more routinely, but then when people are over 18, they are kind of left to fend for themselves. And I was wondering if your numbers and your data might be affected by that.
Thank you very much for that question. So number one, that was just 50. We've got many more patients that we follow. That was just the first 50 that we put for this project. I mean, part of it depends on your healthcare system. So we feel it's better to try and keep people in our system. What we often do is, because in a way, if they stay in our system, then they don't have to go back to the beginning to then come back. So this idea of they can just phone up and come back in if they've not been seen for 5 years doesn't happen. They'd have to go back to their primary physician, then get referred, and by that time it's whatever they had is probably no longer an issue, or it's got worse. So we try and just keep some people just need a very light touch. So we might just be able to phone them up once a year or once every couple of years. How are you? I'm fine. Great. We'll come back in, we'll see you, and maybe come to the hospital in 5 years' time and we'll do a MOT. But otherwise, we might bring them up every year. So we're trying to sort of work out the best model of care, but it is driven a bit by our healthcare system. But we do try and keep touch. So you're right, but I think the children who are coming maybe every 3 or 4 months to have their IV, or 6 monthly to have their IVs alendronate, they're going to have much more contact with the clinical team. Transition's really important. We do a great transition service with Great Ormond Street, and I'm sure other hospitals do as well. And that's if you can get it at that point and then give them a reason for why they need to keep coming through. But again, looking at guidelines for what you should be monitoring in adults, how frequently. There's a lot of work going on now with the ERN and all that. So, we try and keep in contact with most of our adults that we're seeing.